Hello and welcome. I'm Christina Maguire, the President and CEO of MDI Hospital. And I thank you for taking time out of this specifically gorgeous day to join us on our town hall. We're here today to answer your questions, provide vaccine and testing updates, and to share information about what we've been learning as the vaccines are administered and treatments are developed. And that pivots daily. Before we begin, I want to thank you for your vital role that you continue to play in the fight against COVID-19. With 3 vaccines currently authorized for emergency use that offer excellent protection and 1 potential more to be added, we have a reason to be very hopeful. However, we must also remain vigilant with those prevention measures that we continue to remind everyone of: masking, physical distancing, and of course, frequent hand washing. All of those help mitigate the spread of this disease. While COVID-19 vaccines are a critical tool to combating the pandemic, and offer excellent protection for those who receive the vaccine, the CDC cautions that a vaccinated individual can still carry the virus, and it causes COVID. Early data shows that vaccines do help people with no symptoms from spreading the disease, but the CDC and other public health agencies continue to remind us that as more people get vaccinated, we still need to remain vigilant with those prevention measures. As you may have heard earlier, in last week, the governor announced that Maine will accelerate their move to vaccinate those individuals 50 and older starting tomorrow, Tuesday, March 23rd. And all Mainers aged 16 and older, tentatively around April 19th. That all is based on receiving additional dose allocations into the state. This is encouraging news. However, MDI Hospital did not receive any doses for this week. We did receive our 2nd dose allocation, but not our new 1st dose allocations. And we are very dependent on receiving allocation doses each week. We are hopeful, after speaking with the state today, that rural hospitals will start to receive a steady and reliable supply of vaccinations. The state of Maine releases information about their order that they publish each Thursday afternoon on their website, and we will publish it on our website as well, which will show you the dose allocation for the entire state. Outside of those federally dose location sites, such as retail pharmacies, which are the Walgreens and Walmart, and then the FQHCs, who are on a federal distribution list. Given the limited supply of doses available to date, the state's vaccinating strategy has been focusing on those larger max vaccination sites and thousands of doses supplied per week. Their efforts to rural hospitals like ourselves have been mitigated by receiving lower doses. As supply is expected to increase, we are working with the Maine Hospital Association to advocate for more doses at the rural hospital level. And just today, we spoke with Dr. Shaw about increases in dose allocation for MDI and our hospital and our health centers, as well as other rural hospitals. He has promised that they will start to see a steady and reliable dose allocation for us, which will include potentially Johnson & Johnson as well as Moderna. Across the globe, the biggest vaccination campaign is underway in history, with 447 million doses already administered worldwide. With 123 million cases reported globally, more people have received at least 1 dose of a vaccine than have tested positive for this virus since the pandemic began. In the United States, 124 doses have been given to date, with 2.9 million cases reported. So we are making a difference, and we have to remain vigilant about getting vaccines out into our community. In Maine, there have been over 550 doses that have been administered, which includes 25,000 doses in Hancock County alone, with MDI Hospital providing over 5,000 of those doses. Maine cases to date are around 49,000, with 999 in Hancock County, and 86 of those cases were reported positive from MDI Hospital. As we continue to work together to combat the global pandemic, MDI Hospital, our health centers, and the community are very fortunate to have a team of highly skilled healthcare professionals dedicated to this regional response. Today, you will hear from 3 of our colleagues who are at the forefront of our corona prevention and preparedness efforts. MDI Hospital's infection control specialist, Dr. J.R. Krevans, Trevor Casey, our director of pharmacy, and Kate Worcester, our certified physician's assistant who oversees our testing pavilion. Dr. Krevans is the chair of Infection Control Committee at MDI Hospital and has been a guiding force for our COVID-19 preparedness response. He has an extensive background in public health, emergency preparedness, and management of infectious disease. Trevor Casey is the director of pharmacy, emergency preparedness, infection control, and physical therapy at MDI Hospital. Trevor has taken the lead role in our vaccine efforts and administration, coordinating with an interdisciplinary team of physicians, pharmacists, nurses, community volunteers, geriatric specialists, and infection control specialists. And Kate Worcester is our certified physician assistant, who has been our primary COVID-19 testing practitioner and has taken a lead role in providing COVID-19 education, counseling, and contact tracing assistance to residents, visitors, and our school district. During today's town hall, we'll discuss COVID-19 updates, answer your questions, some of which have been submitted in advance and some asked today. If you would like to submit a question during this presentation, please use the function that's at the lower panel of your Zoom screen. It has Q&A on it for questions and answers. We will answer as many questions as possible as time permits, and those that we don't get to or have time to address will follow up via a frequently asked questions document that will be posted on our website. And now please join me in welcoming our moderator, Molly Moon, who will facilitate today's discussion. Molly, I'll turn it over to you.
Thanks, Chrissy. I'm pleased to be here with you and our other panelists today. To preserve as much of the upcoming hour, I'm going to jump right in. Dr. Casey, our first questions are for you to provide updates and clarifications. Our first question is, can you define the term fully vaccinated?
Okay, so this is going around a lot, but this term is really to those that have received both doses of Pfizer and Moderna, or 1 dose of the Janssen or Johnson & Johnson product, and then 14 days after their 2nd dose or after the 1 dose of Johnson & Johnson is considered fully vaccinated. Not a day before then, it's got to be 2 weeks after that 2nd dose is given. This does open up some ability to have fewer quarantine requirements after travel or positive contact. If you have questions about that, please refer to the state main CDC webpage. And I do expect more opportunities will come to those that are fully vaccinated as time moves on. But at this point in time, that's really, if you want to see what those additional expansions are, quarantine requirements, please look at the main CDC website.
Thank you, Dr. Casey. Can you also provide an update on MDI Hospital's call line, vaccination registry, and clinic locations?
I can. So this is a big answer, and there's a lot of detail to this. So because this is changing on us hour to hour, minute to minute, we've had to make some changes, and we really apologize for any confusion that's happened through these changes. As with the changes that occurred last week, we've made some slight adjustments again. And so we did implement a call line for scheduling vaccine, and this was done out of necessity as the processes were changing so quickly that our list couldn't keep up with the daily changes and the ever expanding access to vaccine. In response to the governor's changes, we made some additional changes to our vaccine registration process. So this week, if we get an allocation, I do want to state, if we get an allocation, we do expect to get one, but on Friday, March 26th, our call line will open at noon for those that need assistance. We do ask, if you don't need computer assistance, not to call this line to schedule. If you have a neighbor that can't call in for themselves, we ask them to call in and schedule at noon. And then at 1 p.m. on our webpage, there will be a link posted where those over the age of 50, those that work at a K through 12 education, they're part of an education team, or a front-facing healthcare worker that is licensed with the state of Maine, or a licensed child care provider could sign up. If you sign up with us and you're under the age of 50, we will call to verify why you signed up. So we are going to need to validate that you work for the Department of Education in some way, you are a licensed child care provider, or a front-facing healthcare worker. Front-facing healthcare workers are going to have to provide their Maine license. Child care providers need to provide a pay stub or an ID badge of some sort to show that they do work for a licensed child care provider, and same with an educator at that point in time as well. And that's really how we're going to kind of move forward with our scheduling process from this point forward until changes happen again and we need to adjust. But we do appreciate everybody's patience in working with this ongoing changes. Just so everybody knows, our clinics are being held currently at the Regency. We're so grateful for them and their willingness to be so supportive of these vaccine clinics. They've even offered us additional space throughout the summer to do vaccine clinics. And so we really appreciate their willingness to help and support this great effort in the town of Bar Harbor.
One final quick kickoff question for you, Dr. Casey. As the state expands eligibility, is anyone in these groups being prioritized?
We are still prioritizing our healthcare workers and those that were classified in 1A. We are also trying to make sure we got all of our people vaccinated that are over the age of 70. If you're over the age of 70 or you know somebody that is, please have them email covidvaccine@mdihospital.org and we will work to get them scheduled. We want to make sure that that group is completely vaccinated. And then the healthcare workers, same thing. If you're a healthcare worker and we haven't been in touch with you in some way and you have a license, please reach out to us through that same way or call the hotline or jump on it and get yourself scheduled. Those really are our primary focuses. We do know that we are doing over the age of 50 at this point in time, and then tentatively after April 19th, 16 and older. I do want to just clarify that the state hasn't given us guidance on 16 and older. Currently, Moderna and Johnson products are only approved for 18 and older. And so the Pfizer products, which we haven't had to this point, we would not be able to vaccinate anybody that was under the age of 18. So please, if you're under the age of 18 and you're looking for this vaccine, please watch the Maine CDC website and for updates on how that plan is going to be established for those that are under the age of 18.
Thank you, Dr. Casey, for providing those updates and clarifications. Our next question is for our President and CEO, Chrissy Maguire-Harden. Chrissy, will seasonal residents be vaccinated in Maine, and will the state of Maine be coming up short with vaccines since so many additional residents are in state longer than the summer months for which they typically visit?
Thank you, Molly. The state has not changed their guidance on the website regarding residency requirements, and that guidance is to really have a permanent residence, a domicile for which you intend to remain here for. There is additional guidance for individuals who are moving here for work that we can vaccinate individuals if they have a letter from an employer with the intent to stay longer, obviously, than a few months. So as of this morning, the same guidance is in effect for our seasonal residents. If they're coming here, hopefully they're receiving a vaccine in their state from which they're already coming from. If they've been here with the intent to remain here and make this their home, then obviously they are covered under the Maine residency requirement. And that again can be found on the Maine CDC's COVID-19 vaccination link. It hasn't changed since our last forum with regard to that. We do not anticipate that Maine will be coming up short with vaccines as individuals come into the state. Again, as they may have received a vaccine already in the state that they are living with. If they are up here and remaining up here, we really would like to see as a public health initiative how we can get these individuals vaccinated, but we will do that in concert with the CDC, the state CDC office, to petition for anyone who would need to be vaccinated who cannot travel back to the state of their domicile or residency.
Thanks, Chrissy, for addressing that concern. JR and Kate, the next question is for both of you to respond to. Do the different brands of vaccine protect against COVID-19 differently? And also, what should a person do after being vaccinated?
I'll start with that. First of all, as you look at all these numbers, which I do, the first thing to notice is nobody has tested one vaccine against another. there haven't been 30,000 healthcare workers in England, half of whom got Johnson & Johnson and half of whom got Pfizer. There have been studies where half got Pfizer and half got nothing, or half got, and various other studies like that, but no one has directly compared any of the vaccines with each other in the same patient population. So everything you're going to hear about efficacy comparative is based upon comparing two different studies in two different places. So the first thing I want to make really clear is what vaccine people called severe disease, because sometimes you'll see one vaccine was so-and-so against severe disease, or this. Severe disease means disease bad enough that you missed work that day, or if you came to the testing center and saw Kate, she would say, yeah, you probably ought to get checked out in the ER. Next thing, hospitalization and death is essentially at least 95% and probably close to 100% prevented by all of the vaccines. And that's really the baseline. We're talking about all three plus the fourth, which applied late last night for US licensure or US authorization. All of them essentially provide complete protection against hospitalization and death. So when we're talking about the cases, the 15% or 20% or so that of breakthrough cases, we're talking about people who have a runny nose and a cough and don't feel well. Unfortunately, we're also talking about people who may be able to spread disease a little bit. The basic numbers are that the Johnson & Johnson protects about 70% against the variants, and about 75% roughly against the easier to stop viruses, while the Pfizer and Moderna are probably a little bit better, we think, for minor disease, but only a little bit better against the more common strains, and probably actually maybe not quite as good as the Johnson & Johnson against the variants. The other thing to mention in the comparison is the Johnson & Johnson, also, as Trevor mentioned, it's called the Janssen vaccine. So it's like, let's maximize our confusion. Johnson & Johnson makes a vaccine called Janssen. Also works more quickly, and that's one that is only a single dose. I would have to say, I go back to, I think Fauci's statement is the best vaccine is the one you can get. There are a few people for whom one may be better than another. If you really want protection available, if you have access to Johnson & Johnson, you will get a little more protection in the first 2 weeks. So the other vaccines give some after 2 weeks. And we have some better data with the Pfizer and Moderna products that they protect against transmission, perhaps, but they're very, very close. I would not hesitate to get any of the three. I got Moderna because that's what Trevor walked up to me with. So I took it.
I think all I would really add to what JR is saying is that the most important thing is to be vaccinated with the type of vaccination you can get that's most accessible to you. To go back to JR's point of the 95% reduction in hospitalization or severity of disease is what we really need to focus on. None of these vaccinations were designed when we were even discussing variants, because variants occurred because we designed a vaccine. So therefore the virus started to mutate and change to try to fight off the vaccination process. Just by chance, Johnson & Johnson was doing part of their studies in one of the variant areas. So they did get a chance to study that a bit. We do show that Moderna and Pfizer has good coverage against the British variant, but the most important piece is the reduction in hospitalization and severe disease, as well as the reduction in risk of transmitting the disease to those that would be non-immunized, because that's going to be one of those things we're really going to need to focus on for those individuals who choose not to be immunized, especially those patients who are high risk.
Thank you, JR and Kate. Kate, can you explain what the home surveillance and monitoring system is, as well as monoclonal antibody therapy, who should consider it, and why it seems effective?
Yes. So we'll do home surveillance first. So the home surveillance program is designed for a COVID detected individual who I would consider high risk for possible decompensation. Now that's a pretty wide range for what I would consider, and I've had to learn as the process day by day. I learned there are different patients with different diseases that place patients at higher risk. I do have a long list of sort of those predisposing conditions that place patients at this. But what we do is we give patients a packet. The packet is specifically designed in order to assist them in monitoring their oxygenation, their work of breathing, and their level of dyspnea or fatigue. What we've found as one of the most defining features of COVID and early predictors of severe disease is increased work of breathing. And it occurs around day 3 or 4. And if you're able to describe that to a patient by saying, you know, I'm talking to you on the phone, can you speak in full sentences, or are you speaking in 2 to 3 word sentences? Were you able to climb a flight of stairs yesterday and today you only can climb halfway up? Ways of sort of quantifying that way of defining work of breathing, that has been shown to really help patients be able to define, has something changed overnight? At the same time, they're provided with a pulse oximeter. So the pulse oximetry is read back to me. We follow their heart rates, we follow their pulse oximetry. At the same time as go over the education they've been given on their work of breathing. Each one of the patients that are in the home surveillance program get called every day. They get called every day until they're through their high risk period, which I consider day 3 to until around day 8 or 9, or until they say, Kate, I'm feeling a lot better, stop calling. Like, I don't need this anymore. My numbers look the same every day. Enough of this. When you call and they know you before you even say your name. It's worked really well. I think I'm hoping at the end we can share a story about an individual we have currently doing our home surveillance program that has just been touched my heart deeply. The monoclonal antibody therapy is for an individual who would be at high risk of decompensation, meaning you basically have any underlying comorbidity, you're over the age of 55, and you could have one thing wrong with you. And I could list the list like I had with me last time, but to be quite honest with you, if you're over 55 and you have any underlying pulmonary, respiratory, cardiac, diabetes, you're immunosuppressed and you're younger, any of those, and first 5 days of illness and determined COVID positive, you qualify for the monoclonal antibody therapy. And what this is an infusion of the monoclonal antibody. It is something that's considered an EUA, an emergency. It was approved under an Emergency Use Act because it's something being studied. So as part of that, it is something I go through with the patients as to, this is something that's not FDA approved, but it has been shown to reduce that severe disease progression. We have found that we've been able to use it on one patient so far, and that patient did very, very well, never developed any high-risk symptoms whatsoever, and that was at very high risk for decompensation. One of the key pieces to this is testing early. So not waiting to see if you're going to get really sick with this. This is coming in right away. I don't feel well. I know I'm a patient who would be at high risk if I got COVID. And coming in and us using our Emergent testing program that we have, where we get our test back in 45, 50 to a minute, to an hour, where we can get those results back quickly. I have the patient remain in the parking lot, because if they test positive and they are clinically stable, meaning their oxygenation is at their baseline, their exam is relatively benign, I'm able to transfer them directly over to the emergency department where the infusion takes place, and then they return home. Then they become part of my home surveillance program. I start checking on them daily, see how they're doing until they start in with this don't call me anymore process. But the benefit, and what I really want to stress to the public, is the early detection, that first 5 days. It really has to be that we have you in those first 5 days, or it excludes you from being able to be part of that group, because really it's something being studied or tested at this point. And thus far, I am including as many patients as I possibly can into this group.
Kate, thank you for sharing your expertise on the home surveillance monitoring system and monoclonal antibody therapy. May I also ask you if any of our listeners are interested in learning more, where can they do so?
On the CDC website, on the state website, if you go on to and type in monoclonal antibody, they have a great resource there. I would use their resource as really the best thing that's out there right now.
Great, thank you, Kate.
I just want this is Jerry. I want to put in a sidebar on this because I've run into some people, including medical people, where there's been some question and confusion related to this. Early in the disease, before we had the monoclonal antibodies, there was use of antibodies that were extracted from other patients' bloods, recovered plasma infusions, recovered plasma infusions. And for a while, the Red Cross was really trying to recruit people who'd had COVID-19 to donate their plasma. That has been shown to not be helpful, and that's no longer really being done. But these targeted antibodies that are targeted exactly against the spike protein have been shown to be effective in reducing severe disease and death. So,
and one of the major things we tell patients is infusion reaction is the biggest thing that we watch for, and it's more of an allergic reaction. We monitor in the emergency department, and then I do a follow-up phone call directly after so that they're aware.
Thank you, JR and Kate, for adding to that question. And now, Chrissy, switching gears to discuss travel. Can you speak to travel and the update in travel-based guidelines for April vacation?
Absolutely. Thank you, Molly. And I just want to also just go back, and what an amazing collaboration between our outpatient facilities and our emergency department to be able to offer that type of regimen to really protect our patients. It's been a really important attribute for mitigating the spread and taking great care of our patients. This question is always an interesting question. The state updates their travel guidelines, and we actually have a travel memo that we have internally here at the hospital, and we're constantly having to update that. And JR, it's one of JR's favorite times when I say we have to update this. No, it's not. But let's just go over what this is right now. So, and we'll make sure that we get this in the chat, the link to the main CDC's website. That is a host of really valuable information. And there's a link on our mdihospital.org website as well for your references, with a host of information out there as well. So anyone traveling out of state, coming to Maine, or Maine residents returning to Maine are required to complete a 10-day quarantine upon arrival. Travelers should monitor for signs and symptoms of COVID, and additional 4 days of symptom monitoring. So this means you should arrive with 10 days worth of food and supplies, that you should not plan on going to public spaces, and that you should avoid contact with anyone, especially who has a high risk of severe disease. Now, you can opt out of that quarantine if you follow specific guidelines, and that requires a negative antigen or molecular test result. We refer to that as a PCR test or an antigen test. Antigen tests are not prescribed for asymptomatic testing, so they're really for someone who might have symptoms. We actually prescribe the PCR testing. 72 hours before arriving in Maine, to forego the 10-day quarantine. And of course, that test needs to be negative in order for you to avoid the quarantine. Quarantine testing exemptions. So this was just updated earlier in March, and there are now exempted states, and those exempted states, which means you can travel freely between these states and come back to Maine and avoid the quarantine and or testing requirement. And those states are Connecticut, Massachusetts, New Hampshire, Vermont, and Rhode Island. I recently learned from this last town hall that individuals can travel freely back and forth, but not all of those states on our exemption list have us on their exemption list. So Mainers traveling to those states may have additional requirements for quarantine or testing. So there's a know before you go section on most state websites. I encourage anyone traveling, please become familiar with this. And then there's a vaccination exemption, which just went into effect last week. So individuals who have completed their COVID-19 vaccination series and are 14 days beyond the completion of the series are exempt from testing in the 10-day quarantine and 4-day additional symptom monitoring. I will use and coin a phrase that Dr. Shaw uses. The word that's working here is fully vaccinated. And what Trevor explained to you earlier is that is after your second dose of Moderna or Pfizer, and after your first dose of Johnson & Johnson or Janssen, 14 days after those doses, you are then considered to be fully vaccinated and you would qualify for the exemption. And certificates of compliance remain in effect right now. So if you come into the state, you are, and you might be staying at a hotel or visiting somewhere, you would be required to certify that you have in fact done the quarantine, or you have tested out of the quarantine because you've had a negative PCR or antigen test. So that is where it stands right now. With regard to this. Now, in May, we have been told in the CDC's announcement that this whole exemption list is going to tip upside down. And what I mean by that is instead of having those states where you could travel freely to, we're going to see those states where we cannot travel. So as more vaccinations occurred nationwide, the CDC will have a pulse on that and they will be updating this list. So it's very helpful to just frequently visit that exemption list, and the exemption list again in May will flip upside down and be used for other reasons. For upcoming vacations, let's really think about how to be cautious about travel, about cohorting with individuals who are not vaccinated. You really need to understand that we see upticks in positivity rates around February vacation, around the holidays, and hopefully we won't see it in the April vacation timeframe. But we do want to reinforce that it's incredibly important to do and exercise our prevention mechanisms. Please mask. Just because you're vaccinated does not mean don't mask. It's really important to do that, to distance appropriately, to avoid individuals who you might be a carrier, even potentially as a vaccinated individual. So we want you to all have a wonderful vacation time. Everyone deserves respite, but do it cautiously and follow the state guidelines as you do embark on any traveling or getting together with friends and neighbors and family.
Thank you, Chrissy, for sharing those updates, clarifications, and precautions. For our live listeners, the link to the main CDC website on COVID-19 updates has been included into our chat. And now, Dr. Casey, our next question is for you. Can you speak to the transmission rates and the choice against vaccination? What is the impact of vaccination in the workplace?
So recent studies have shown that the Pfizer vaccine has about 95% chance of preventing transmission. And most people believe that that's going to be very similar for Moderna. These are very, very recent studies, and they're still being reviewed. But it is good and it's exciting, and all three current vaccines, approved vaccines, are being compared at this time, and so that's good to know that we're not going to have asymptomatic transmission if we did get COVID after being vaccinated, and we're continuing to get that shored up. And workplace, if you have an opportunity to get vaccinated, that just protects your family, it protects your coworkers, it protects your customers. Please take the opportunity to get vaccinated as quickly as possible.
Thank you, Dr. Casey. And Dr. J.R. Krevans, can you address the current masking standards? Is double masking more effective, and which order should the masks be in?
So, I mean, the most effective double masking is a mask on both people. Let's start with the basics. If there's a mask on both people, there's far fewer viruses being put out into the environment, and then your chance of breathing them in is much less. When people talk about, so that's always my starting point. When people talk about double masking, what they're referring to is essentially using one mask to improve the seal of a second mask. The recommendation is a shaped cloth mask, which has a good secure fastening over one of the laminated paper masks, a procedure type mask, surgical mask, they have various names. The reason being that those masks, the procedure type masks, unless you're really careful in how you fit them and are very experienced and they happen to be just right for your face, which is, of course, you know, there's sort of one size fits a few people, but everybody gets the same size. So if your cloth mask that you find fits your face well, secures across the bridge of the nose, down the sides of the cheek, and either tightly against the front of the chin or usually better just under the chin, that mask then seals the laminated paper mask, the procedure mask in place. So in addition to getting the extra layer of filtration, what you really get is a very good seal. So the air that goes in and out has to go through the mask as opposed to around it. Essentially what you're doing is creating something that's very similar to a rated mask. So one of the people who wrote in this question asked about, you know, where would you put like a N95 or a KN95 with this system? And the answer is you wouldn't, because those masks are by definition a double mask in and of themselves. They have the formed rim and a secure attachment system, which gives you that good seal. And then they've got a very high efficiency filter. So if you have a proper fitted to you N95 or KN95 or N100, various masks that people get that you're wearing, you don't need a double mask. If you are, I would especially recommend double masking for any time you're going into a situation where you're thinking, I'd rather not be here, but I need to go there. Going into a crowded store, especially if you're at high risk and haven't been vaccinated yet. If you work at a place where there's a lot of people coming in and out all the day and you don't have good air circulation. If you are taking care of a relative and you're worried because your work carries you outside and your relative is at high risk, those would all be, you know, places where you might really want to do this. Some people like to do it all the time and it can be very comfortable. The paper masks are nice against your skin and the cloth mask fits well. I will add at the end of this that one of the biggest things you can do, and it's getting a lot easier this time of year, is making sure there's good airflow out of the room. Ventilate your rooms, especially, you know, if they are occupied by multiple different people who are not in the same family, because that is one of the biggest things we have now seen is good ventilation makes a huge difference in terms of preventing the accumulation of small particles that can sneak in.
Thank you, Dr. Krevans, for advising us with the current masking recommendations. We have a number of questions in our Q&A regarding COVID-19 symptoms. Kate, can you share with us, what does a patient look like with mild symptoms, moderate symptoms, and severe symptoms of COVID-19? And what symptoms can one expect after vaccination? And can you also explain the use of emergent testing at MDI Hospital?
Yes, we're gonna do that in pieces. Mild, moderate, severe disease. Mild disease looks like any common cold: runny nose, body aches, sore throat, dry cough. One of the predominant symptoms that I always consider to be what I would say high risk for having disease is loss of taste or smell. It tends to happen on day 5 to 7, but patients don't think anything about their lingering low-grade cold until they lose their taste or smell, and then they come in for testing. Moderate disease would be increased work of breathing, feeling like you're more short of breath than you should be, presenting to me at the testing facility and being found to be below your baseline of oxygenation. That's what I'm just defining that for myself. So if your normal oxygenation is somewhere between 96 to 98, which would be considered normal, you're oxygenating somewhere between 94 to 96. I'm going to consider severe as any patient who I have to transfer to the emergency department for supplemental oxygen because their course is so unpredictable. Patients that present to me, from what I have experienced, and this has happened many times now, who are COVID detected, who are hypoxic, meaning oxygenation below 90 to 91%, who require supplemental oxygen, their course is unpredictable, and much of that is based on underlying comorbidities. What we do know is that our early therapies and early interventions have decreased mortality drastically, and that we're able to take that severe patient and take good care of them and actually really improve the quality of their life and their risk of decompensating by having these early interventions. We have our antiviral therapy, we have our monoclonal antibody therapy for the early onsetters, day 0 to 5. We have antiviral therapy now that's available for those patients that would have exceeded the 5-day. You're still within the 5-day, you could have gotten both. We've found that supplemental oxygen through high flow, our high flow nasal cannulas that we have are actually preferred over the more invasive forms of oxygenation that we did from the beginning. So those are more severe patients. Those patients that get transferred into the hospital, each one of them is receiving therapies that are really new and groundbreaking. But the most important piece is that the mortality rate, if you start to look at it, it is drastically declining because we know how to take care of patients so much better. This virus isn't unfamiliar to us anymore. We understand a little bit about it, enough about it to take good care of patients. What was the next part of the question? I don't have all the questions in front of me.
The next part was, what symptoms can one expect after vaccination, and can you explain the use of emergent testing at MDI Hospital in coordination with that?
After vaccination, as Dr. Krevans described to me, you can experience a wide arrangement of symptoms, all which could be considered short, is the most important thing. So after your vaccination, the most common symptoms tend to be, if you've got Moderna, is going to be arm pain, feeling like you have a Charlie horse in your arm. You can have body aches, low-grade fever, mild flu-like symptoms. We've found that the younger individuals and those individuals that are of smaller BMIs, when they receive their second dose, have a more profound vaccination reaction with 24 to 48 hours of fever, body aches, head to toe, just not feeling well, arm aching, just really not feeling well, but at the very most that lasts for 48 hours. I have seen a few individuals who have had allergic reactions at the site. If they have a mild reaction at their first vaccination, I pre-dose them for their second vaccination, and all of them so far have done absolutely fine with their second vaccination. The third part of the question, the emergent testing, I don't call it rapid testing because, as Chrissy was talking about earlier with the antigen testing through Walgreens, that is a reliable form of testing when you're symptomatic and you need to find out right away. It is not reliable when you're asymptomatic, and it's not as reliable if you're symptomatic and really looking for solid, accurate results. But we do have the ability of doing PCR emergent testing, which is in-house. We have 2 separate machines that do it, and we get results back in around 45 minutes. And that's really used for patients who potentially will receive monoclonal antibody therapy, patients who present with moderate disease, so I'm concerned I might need to transfer them over to the ED or at least send them home with a surveillance kit. Those individuals who may have exposed quite a few other individuals and getting emergent results will really be able to do contact tracing much more sufficiently and efficiently. And those individuals that maybe work in a place where it would be, extremely detrimental to those around them, where we need to really get those results back emergently.
Jerry, I want to add a couple little things into that. One of which is the reason we don't do the Emergent test on everybody is we only get a limited resupply and we don't want to run out. It's a spectacular test. It's just as accurate as a send out test, and it's done in 45 minutes. It's just we don't have an unlimited supply because they're on national, like so many things are on allocation. One real important question that I get asked by email probably every day or two by one of the other practitioners or various other ways is if you've had a reaction to the first shot, should you not get the second vaccine? And the answer from both the CDC and the FDA, based on the current evidence, is the only reaction to the first shot that would mean you should not get your second shot is if you have an immediate severe allergic reaction. So in other words, if you get the shot and 30 minutes later your tongue swells up and your nose looks like a giant plum, you should not get a second shot. But if 5 or 6 hours later you've got a rash on your arm and it's sore for a couple of days, that is just a sign that your body knows how to react to COVID, and you want it to remember that. And you should get a second shot to ensure good immunity.
Thank you, Dr. Krevans, for offering your insight on that. And thanks, Kate, for describing each of those scenarios with us. For Chrissy, as far as testing goes, for patients who are fully vaccinated, does it make sense to be tested for asymptomatic testing?
Well, Molly, that is a great question for which we are still doing some research on, but let's just talk about asymptomatic testing and we'll tie it into the fully vaccinated cohort of individuals as well. Asymptomatic testing is something that MDI Hospital has really promoted this past year. We partnered with the state, we partnered with the school districts, as well as learned so much from doing asymptomatic testing on our front-facing workers. And in our Birch Bay Retirement Village do asymptomatic testing on our workers there as well. Part of what asymptomatic testing does is it really starts to tell you the prevalence of disease. And for us, over the summer months and throughout the winter and into this new spring we're experiencing, we continue to do this type of asymptomatic testing to get a sense of what is happening in our community and having an action plan on how to mitigate the spread of COVID should we find it in particular cohorts. And when you think about that, our front-facing workers last summer were tested routinely to make sure that they were not exposed to COVID. We had no positives in that cohort. We partnered with the Jackson Laboratory and did asymptomatic testing with their entire population of workers over a 6-week time period. And there was minimal asymptomatic positive results there as well. We continue with the school district to do asymptomatic testing. This allows us to get ahead of any kind of potential outbreak. And then Kate has to do her contact tracing, which can be incredibly difficult and detailed, but it allows us to start to mitigate that spread. So when I asked this question today of Dr. Shaw around what is the efficacy of continuing to do asymptomatic testing with regard to individuals who are fully vaccinated, it's really important for us as we start to plan for our summer and having that opportunity to continue to do asymptomatic testing for front-facing workers and beyond. His response is they have not given federal guidance with regard to the efficacy of continuing the type of asymptomatic testing that we have been doing. His intent is to be able, if they don't publish something probably in the next 10 days, because the research is starting to come to fruition, and JR has been, of course, doing what he always does in his due diligence, reading every research study and paper there is. We're starting to see that there really isn't a efficacy of continued surveillance testing for individuals who are fully vaccinated. Dr. Shaw is hoping if the federal CDC does not post something in the next 2 weeks, he will post something with regard to the update on fully vaccinated versus asymptomatic. Again, because our vaccination rates, although we're going in the right direction, we live in a community that has not have access to full to vaccinations. So when you think about the 60 and above, you think about those healthcare workers, and then our school district was just given access to vaccines. We are somewhere around the 20th% of vaccines in our community. That's 80% who still have to either been given the option to vaccinate or have opted out of vaccination. So it's important to still use asymptomatic testing while we await for full vaccination of our community.
Thank you, Chrissy. Kate and JR, can you speak to the latest spike in numbers and what we can expect from the upcoming April vacation?
I'm not convinced we know why the latest spike is there. There's not great data, and it actually may vary from state to state. And of course, what happens in one state, what happens in Vegas does not stay in Vegas. It gets on the plane and comes home and spreads to your children, who then bring it to their sports team, etc. So some of it, I guess we'll start by saying it is clear that there is a small increase in numbers over the last 3 weeks in Maine. It's not a big increase, but what was a decline is now a very slight upward trend of about 5 to 10 cases per day more each week. Many people, based on behavioral surveys and some observations, feel that it is due to people letting down their guard, and that people are just sick of having to do this. It's been a year. Some of it may be people who are choosing to do it on the grounds that, well, gee, we vaccinated the old people, so we don't have to worry as much, which has some validity, but there's a lot of older people and other people at risk who have not been vaccinated yet. And we'd like to keep our schools open. So, and some of it may be due to travel over the February holidays, and cases that sort of accumulated them and then spread into the community. There have been some occupational outbreaks, both in our county and in nearby counties, that are clearly related not to people getting it so much from their customers, but employees typically spread it to other employees. That's true in hospitals. No, we have not had that in our hospital, but other hospitals in Maine have had that. That's true in nursing homes. That's true in factories, that what happens is people decide they're going to eat lunch together without their masks on, or they're working hard next to each other and breathing hard, and their masks don't always neatly stay in place if they're on at all. And you will get sideways transmission in these workplaces, and then it spreads into the community. But I do not think anyone has really hard data to say it's one single thing. I will mention, in other states, there have been a clear choice. Many other, a group of states, primarily across the southern areas, have made a choice that they're no longer going to try and control COVID spread. And they have chosen to encourage people to socialize and do business without protecting each other.
I'm just going to add, JR knows the data nationally. I can say just from clinically being the frontline person in contact tracing of the actual local cases, it's almost always an unmasked activity that was inside, that was related to family doing what families do, which is love one another, interact with each other. A child comes home from college to say hello to their parents and inadvertently is, found to have a mild cold days later. It's never something where we always can trace it back to something. As long as people are doing pretty good about limiting their exposures, we can trace it back to one person. And it's unfortunately, it's always what I have seen, an unmasked interaction where those individuals really aren't following any of the social distancing requirements because they feel like they're surrounded by family and friends. But yes, we've certainly seen an uptick in numbers, not substantial. I've seen that sort of trickle down over the course of the last few days, and I hope for that. My concern is the April vacation. We all want to go see our loved ones again and have our children come home. The same sorts of things happen. As much as you can try to do those interactions with good ventilation, to test if you are traveling, and to try to follow those, those social distancing guidelines within the home as much as possible, it really does reduce transmission.
Thank you, Kate Worcester and Dr. J.R. Krevans, for speaking to that slight increase that we're seeing in the state of Maine. Dr. Casey, I actually have 2 questions from our Q&A that may dovetail. First, if I am a caregiver of someone in the groups being vaccinated, can I be vaccinated too? And second, how are the extra vaccines being allocated at MDI Hospital, if any?
So the first one's a question we get a lot about caregivers. There are some caregivers that are licensed medical providers, and they fall under being a front-facing healthcare worker. If they are currently have an active license, they can contact us and we'll get them vaccinated. If they're just a caregiver of their family member, and I don't just mean just a caregiver, but without an active current license, then the way that they're going to qualify is by age. And that's so when they come into their age group, if they're 50 and over, they can get vaccinated. And then hopefully by April 19th, as long as the vaccine quantities support it, they'd be able to get in line and get vaccinated. So, but that's really that piece of it. What was the other question? I'm sorry.
The other question was, how are the extra vaccines being allocated at MDI Hospital, if any?
So we don't really have any extra doses. We are able to get an extra dose out of a vial of Moderna. About 8 out of every 10 vials, we're able to get an extra dose. 11 doses instead of 10 doses out of the vial. And so what we do is we actually schedule people for those doses. We don't leave any any doses unscheduled. And then if we do have an extra, we are using those on our inpatient floor and with other people that have signed up or contacted us, healthcare workers, those type of people that are those top priorities, and we're continuing to use those vaccines for those people. I saw in the comments that they are looking at other high risk, asking if we're going to look at other high risk conditions. Absolutely, but we're still working on healthcare workers and using those doses if there is such a thing based on a cancellation to make sure those people get vaccinated first.
Thank you, Dr. Casey. And Chrissy, can you address what does it cost to be vaccinated and what does that cover? Why is there a charge for symptomatic testing?
So the Molly, I want to make sure I heard that right. The cost for asymptomatic testing or for vaccination?
Why is there a charge for symptomatic testing and what does it cost to be vaccinated?
All right, so for symptomatic testing, there is a charge for the evaluation for the testing supplies. Unfortunately, these supplies, as JR alluded to, are on allocation. They're not, they are expensive and they have to go through a resulting process. In addition, when you go to the testing facilities, Kate or her colleagues are out there to assess you. And so you're actually getting a healthcare visit. So you're getting an assessment. You're being determined if you're going to be swabbed. Most often we do swab and have that sent out to a resulting location. There are many testing locations we use. There is a state location. They are typically very behind in getting the results back. So we choose to use either what we call a resulting lab, either in-house or externally, that can get us your test results back quickly in order for us to be able to further your care plan. So that is what the charge is for symptomatic testing. With regard to the vaccine is what we call a state supplied vaccine. It's actually supplied through the federal government to the state. There is no charge for the vaccine. There is an administrative charge. At this time, we are not able to charge for that administrative charge. So there has been no charge for the vaccine to date from MDI Hospital and our health centers and our community vaccination clinic.
Thank you very much, Chrissy. And Kate, to end today's town hall, can you share with us an uplifting story that you recently encountered?
Yeah, I'll try to be really brief. We only have a minute left. I always try to find a silver lining in talking with individuals who have coronavirus and are scared. And in the last few weeks, I had an interaction with a middle-aged man who's developmentally delayed, who came in and thought he had his common cold, but was a very high risk. And because we already knew there was someone else positive at an interaction he'd gone to, and did test positive. And I put him on the home surveillance program because being developmentally delayed is a risk factor. That part of you that says my increased work of breathing seems out of sorts might not be triggered as early as somebody else might be. So I gave him the surveillance kit. We actually had a medical provider from our hospital drive it over to his home and drop it off with PPE on. And then I call him every day. And if you can imagine explaining a pulse oximeter to someone who is really struggling just to understand this apparatus he's got to put on his finger, and that there's two numbers, and when you look at it in this direction, it's totally upside down from this direction. And so he would keep saying to me, Kate, can't you see through my phone? Can't you see through my phone? And so we actually got him set up so we could FaceTime so that I could see through his phone, because I couldn't see his numbers. And if they were one way or the other, it really made a big difference. And I called him today and he said, I've got the numbers down. I know my numbers, and stop calling me. And I said, great, we will leave everything outside of your door and we will have somebody come pick it up. But we've had things like that where, there's a lot of individuals who don't have any resources when they get this diagnosis. And we all need to remember we're a community and we're a neighbor and we're a friend. And like this individual, we were able to pull together some resources and some people to help him. And I really feel like he felt kind of just touched with the whole process by having that phone call every day.
Oh, thank you so much, Kate, for sharing that with us. That was our final question for today's town hall. Thank you, panelists, for your time and expertise. Chrissy, I'll now pass it back to you to close.
Thank you, Kate. You got me again, boy.
Thank you.
So I'm always touched with those stories, and it just resonates so much of the work that you three do. I'm so grateful. And thank you all of this community that has banded together to make sure that we stayed safe, that our residents, our families, our patients, and each other were taken care of. And to these three panelists, they have been working over a year nonstop. Their expertise, their dedication through this pandemic has been a guiding and beacon to our community, but also to this organization, for which I'm deeply grateful. As we look forward to a time when we actually can see each other outside of tiles on screens, we'll gradually reverse precautions. We will gradually open back up this state, but we will do that under very careful guidance. And again, we have to remain vigilant with our prevention measures of masking, physical distancing, and frequent hand washing to mitigate this. As we all work together, we're planning on doing the same type of education and prevention work we did last summer for our community, with providing masks for our businesses in town, also providing education with our boots on the ground community educators, and support everyone as much as possible. So we do thank you for your ongoing commitment to the health of our community and making it the vibrant, wonderful place it is to exist, and for your participation in our discussion today. We do know you could have chosen a very, very different place to be outside today. So thank you. Stay healthy, happy, and hopeful, and we look forward to seeing you again soon.